2024. It is 5:32 or 3, depending on which clock I look at. So welcome everyone. Thanks for being here. Item number 1 is public comments. 2.
We have only one person online. We don't see Ryan here. I don't see Ryan online. So Carolyn, I'll make you presenter, and you can start whenever you're ready. And I'll give you a reminder at 30 seconds.
Can you hear me? Can you hear me?
Yes, we can.
And can you see me too?
No, we can't see you. You can turn your camera on.
Okay. Okay. So am I on now? Okay, I'm not going to worry about that. I thought I had turned it on, but let's see. Okay, I don't know if that's on or not, but my name is Carolyn Beninsky. I live in Boulder. I've spoken to this board multiple times, urging you to stop promoting COVID shots. Today, I'm asking you to stop promoting a different vaccine, which is neither safe nor effective, and which prior to COVID had the highest rate of adverse effects reported to VAERS. I'm talking about Gardasil, manufactured by Merck. Gardasil was first approved by the FDA in 2006 to prevent infections by the human papilloma virus, although in a majority of cases, the natural human immune system clears HPV on its own. Links to the CDC on the BCPH website claim that Gardasil prevents cervical and penile cancer, but no study has ever proven that. On the contrary, some studies have shown an increase in cervical cancer among vaccinees. Gardasil is typically given around age 11, while cervical cancer is typically diagnosed in women 50 and older. The HPV vaccine's clinical trials were not designed to determine whether it prevents cancer 40 years down the road, and the post-marketing studies do not support that claim either. Gardasil's safety surveillance report in 2009 did, however, show that there were 3 times more adverse events reported for Gardasil than all other previous vaccines combined. Gardasil is associated with fainting, autoimmune, neurological, and reproductive disorders, chronic fatigue, chronic pain, fibromyalgia, and a number of other serious medical problems. 110 lawsuits against Merck for debilitating injury or death due to vaccines are currently consolidated in multi-district litigation, and an additional 145 are pending. The Vaccine Injury Compensation Program has already paid $70 million in damages and awards to children injured by Gardasil, and 205 more cases are pending in the compensation program. Rather than promoting Gardasil shots, BCPH should provide informed consent and urge parents to be vigilant about Gardasil's lack of efficacy and its risks to their children. I have presented this evidence in writing to you. I sent that in today. I had sent it in earlier as well. So thank you very much.
Thank you, Carolyn. And it doesn't sound like Ryan is here. So if Ryan joins us later, he can maybe got some time, he can add his comments. So thank you very much. That concludes public comments. Item number 2 is approval of the March 11th, 2024 regular meeting minutes. I move to approve the March 11th, 2024 meeting minutes. I'll second. All in favor? Aye. Aye. Okay, I think that's everyone. Minutes are approved. Thank you. Item number 3, standing agenda item budget update.
Hi, everyone. Can you hear me okay?
Yes.
Okay, perfect. So today I'm going to give you the system updates since our last meeting. Start with, we've been working with OFM to finalize our payroll data coming from Dimensions. And the staff, our grant accountant and our senior accountant were able to identify some errors in data that has the whole county waiting for the corrections that will be reloaded. So this was a county-wide error, but our staff were able to catch it for the county. So we're very excited that we were able to contribute in that way. I also wanted to share that our audit date has moved to May 1st because of this delay in data. So we are aligning ourselves with the county and the audit date so that there's a better likelihood that we will reach that deadline since the county will be pushing towards this day instead of our initial date of April 15th. Any questions on those two items?
No, thank you.
Not a problem. I think I didn't announce myself, so I will do that now. My name is Desiree Casarosia, and I'm the finance manager for Boulder County Public Health, and I use the she and her pronouns. The next data item I'd like to share is that we will be attending the county training, Budgeting for Equity, and this will be part of our priority-based budgeting that we will be implementing. The kickoff is tomorrow, Tuesday, April 9th. The budget and finance team were able to reclassify $1.7 million in transactions to PH13. As you'll remember, this was a county request to us at the end of last year. We were not able to track all of those expenses because there were several that were of a lower amount that we addressed in the last meeting. But I wanted to give you the amount that we were able to reclass. Work is still in progress to update the 2023 and 2024 budget information in OpenGov. We're working with our senior budget analyst, Mitch Goodwin, on this, and we are going to just upload all of the changes at once. So there's been a little bit of a delay from our anticipated high level correction because we're going to do all the corrections in the same amendment. The next item I've mentioned before, the county is testing a new functionality in Oracle to allow for indirect transactions to be booked through the project instead of tracking it separately. And the last item I wanted to mention is that Boulder County Public Health staff met with the Office of Financial Management to collaborate and discuss public health, and we discussed some of OFM's policies. And I think it was a good exchange of information, and it was discussed that we may do this quarterly going forward.
Hey, Desiree, before you move on, can I ask a quick question about the reclassification to PH13?
Of course.
I know we had the estimate was like a couple $100,000 expenses that we're not able. Is that still what it was?
Yeah.
Okay. So
We were working on itemizing some of those. I don't know if those will be requested by the commissioners going forward, but we'll work on pulling that information together so we have it.
And so I guess my question is also, is that something that won't be an issue next year now that we've
it won't be an issue because we've set up all of our systems to accommodate this shift into using the operating for PH13 for all county funds that we receive. With the exception of perhaps Marshall Fire and the mosquito tax, that's still to be determined. Any other questions that I can answer?
Not seeing any.
Okay. Thank you.
Okay, great. Thank you. Item number 4, reserves full approval.
Hi, I'm Catherine Palmer. I am your Director of Admin and Finance, and I use she, her pronouns. Today, I'm going to go over the draft policy overview that we discussed previously. We made a slight change after our last board meeting in February, where we were going to provide different options in terms of policies that were out there. And instead, the request was to actually draft a policy recommendation. So that's what we're going to go over today. So just a couple highlights in terms of how we pulled this policy together. We did research based out of the Government Financial Officers Association, or GFOA's database. They have a database of quite a few policies that governments hold. We also pulled from Boulder County's policy. There's not a ton that we were able to take out of their policy just because their setup is different because of how their finances flow. But I can highlight for you where we pulled from that. And then we also reached out to LPHAs. There was not a single LPHA was actually open to sharing one with us, so we did not get one from them. But another component that we were able to implement was it wasn't CDPHE, I believe, Desiree, but Desiree found a state fund balance PowerPoint that was just released recently. And that helped inform some of our decisions as well. Desiree, do you remember who the source was on which agency it was?
I believe it was the state of Colorado, and it was their education division.
Those are the reference points that we used. And then also conversations that we've had collectively as a team to identify what the needs were and what we were seeing for BCPH. So those are all of the elements that went into building this out.
Sorry, Catherine, before you move on, you said no other LPHAs were willing to share a policy, but we do know what other LPHAs are using in terms of their reserve fund
Yes.
percentage.
So they filled out a survey that CalFO put out. And then COFAD did a follow-up, that's the Colorado Public Health Administrative Directors team. Specifically within the COFAD committee, they put out a survey asking people about their fund balance amounts. So we had those figures, but we didn't have actual policy copies that laid out how their approach works. Okay. All right, so I'll keep going. So the way that we drafted this is just an acknowledgement of a resolution in terms of the normal whereas that you typically see at the top. And then we identify the purpose just to align our fund balance for good overall financial sustainability and stewardship. We acknowledge that we are utilizing GSAB number 54, which is what most governmental agencies reference when they're doing their fund balance policy. And then we go into overall definitions about what the different terms are. So first, we're talking about the general fund and what the general fund encompasses. For public health, what the general fund encompasses is anything that is not given to us by the county, that is not given to us by a grant or state grants or any allocations that we receive. So at the end of the day, that's going to be largely our reserves, as well as the fees that we bring in that stay with us. So that's largely what's going to be in our general fund when we're taking a look at it. And then we go on to have the fund balance classification, which is acknowledging what the fund balance is meant to do, what its focus is on, and then the fact that it breaks out into 5 different categories. And that is the area that I wanted to spend a little bit more time with you on today, just to acknowledge this is how our fund balance has been laid out. It's how all governmentals are laid out, but provide a little bit of a snapshot to help acknowledge the way it works. When we talk about fund balance, because there are a lot of different moving pieces. There's also an aspect in here that we are suggesting that is added, so I'll go into detail on that as well. So if you want to move to the one that has the 2 visuals. And if we want to pull any of those ones up a little bit more, Jordan has them ready to go. But the first one, and we're just going to go from left to right. So the first one is non-spendable. These are the amounts that cannot be spent due to their nature. So it would be things like prepaid amounts or equipment. So if you look on the left, or sorry, on the right side of the document, We don't actually have anything in non-spendable. You can see it between the yellow and purple. In the past, we have had equipment that has fallen in there, and we had some components related to IFAS. But as of right now, when you look at our fund balance, there is nothing in non-spendable for us. Next, you have the restricted fund balance. These amounts are constrained for a specific purpose, typically by external parties, constitutional provision, or enabling legislation. So those are going to be the aspects like TABOR that we have to abide by. Another aspect of this, and that's that kind of peachy color that you can see. So it's all three of those that are listed. We have a potential rent liability. We don't know what our rent is going to be, and our county attorney asked us to set that aside as decisions are being made in that space around some aspects where we might be billed. So until our county attorney tells us to remove it, we will leave it in that space. And that's typically what stays in there. Only those officials can decide what comes in and out of that spot, and it's for specific regulatory reasons. Next, we have the committed fund balance. That's going to be underneath the pink, there's the yellow one. And so what we want to acknowledge in this space is that the committed fund balance, whenever you see those are constrained for a specific purpose by the Board of Health. So you are really defining a resolution for those to be either approved or moved around a certain way. So right now what we have that falls in committed is two components, one that has been there and one that we are suggesting be added. And then the other aspect is within our unrestricted. You can see there's like a committed two yellows that are right there. That's what's to help balance our overall budget. So when we submit our budget to you and say, we're going to use this much reserves to balance our budget, that's what you're approving. And then we have a rollover amount that typically comes in from the state. But let's go back to emergency and the one that we're suggesting. So right now there's an emergency preparedness contingency. Working with Jordan and Patrick, we tried to do some historical work to find where there was language written that identified how the emergency contingency could be used, and we were not able to find it. So we thought it would be good to put that actually into language to identify what the purpose of that is and how it can be used. So here you'll see language that identifies during emergency or natural disasters, the Board of Health annually votes on the level of funds set aside in this contingency balance. That was brought to us by auditors last year who acknowledged they wanted to see a vote on that every year. So you'll vote on it when we do the resolution. And then when those funds need to be utilized, the executive director and director of admin and finance will prepare a resolution identifying the amount and use. Funds should then be allocated each year in the budget process to replace any use of the emergency contingency fund during the preceding fiscal year to maintain the balance approved by the board. So that's a language that we've updated in that space. The next aspect that we're suggesting be added in, which allows for better oversight and management from the leadership team on Boulder County Public Health, is the annual contingency fund. So we saw a few different governmental entities that had set this aside, and it's a specific amount, typically 1 to 3% is the average that we saw. Some went a little bit higher just depending on their budget amounts and what they may use it for. But what they were suggesting in this space is that we set aside 1 to 3% that allows for uncertainty in any budget area that can cover minor unanticipated needs of non-reoccurring nature. We always have this on a regular basis that happens, but this allows us to say this is the amount. Specifically, how much has been approved, we can go up to this amount. And this is where we see like program exception requests come in from our teams when maybe they need supplies or there's a gap in funding that they weren't expecting. We have the availability and the maneuverability within our budget to make those updates and changes. So that's a suggestion that we're asking to be added into the committed fund balance, and that would be presented to you. I will take a breath and see if there's any question.
Question on that, since it's a non-recurring nature. So that 1 to 3%, we could not use that for a budget shortfall for salary under part of our budget. Is that correct?
You could use it for salary if it was identifying it was for like a short period. Say that you had a grant for an individual, the grant ended sooner than you were expecting it to. So it would hopefully be non-reoccurring. And then you wanted to cover the individual while the program went out to look for additional grants. Okay, I'm going to move on to assigned. That's the purple color. So assigned is funds other than the general fund. These amounts are any remaining positive amount not classified in the above listed categories. So if we again go left to right, if we take the non-spendable amount, the restricted amount, and then the committed amount, anything that has already been pulled out of our fund balance. Now we're looking at assigned. That's what's left over that we have some room to look at. So you can see at the bottom, we've got this total assigned reserve fund balance. And this is based off of when we submitted the budget to you last, I believe it was December, we had the budget cuts. So you can see in there that we had 4.8 that was remaining total assigned. So then we move into unassigned fund balance. These amounts have no restriction of any kind. By definition, a positive unassigned fund balance can exist only in the general fund. So what we see is we remove out the amount that we need to have for fund balance to actually meet our reserves. That's that 3.3 million and the 180 rollover. And that leaves us with 1.2 of unassigned fund balance. That at the end of the day is what got us to our 5%. So then we have our unrestricted, and unrestricted is just a collection. So you can see the pink is all three of those combined. The restricted is what we have been told that we either cannot move or cannot touch because it's actually not a product. So it's equipment or restricted. And that's again by constitution, legislation, any of those aspects. And then everything under the pink is really things that we have the ability as the board and BCPH to make decisions on. So again, you can move around what's in the emergency fund. You can move around what's in the annual contingency fund. You can approve what we use in reserves to cover the gaps, all of those aspects. So any questions about this? We could also go into the pictures and make them bigger if you want to see them. Any thoughts?
I've got a question about the 5.3 total unrestricted fund balance or the 4.8. I'm not sure which one. Is this part of the miscommunication or misunderstanding that we were having with the commissioners in terms of what we had in our fund balance? Why it looked like we had more funding than we did?
So I'll start and then let Desiree hop into this one as well. So yes and no. The Board of County Commissioners as well as OFM don't see this. They see what is submitted in Oracle and what's in OpenGov. What we did realize, which again was an area that we're doing cleanup and have found that we have accessibility and flexibility in, is that when we first submitted our budget into OpenGov, we were told it had to balance. So it fully showed our revenues plus reserves as well as our expenses for a fully balanced. What they did not understand is that the reserves were in there to cause it to fully balance. And so in 2024, what will happen is when we submit our budget, it will not count it. So they did not recognize that our reserves were actually being counted. They thought it was just our overall budget. Do you want to add anything to that, Desiree?
I think you summarized it really well. The implication of the commissioners looking at the numbers in Oracle led to them thinking that we had revenue of an extra $2 million, which was actually the reserves that were included into that budget number in addition to the reserves that they were seeing.
Other questions?
Heather, this may be a basic question that I just need offline explanation, but are we suggesting that we're moving from this number 3 at the top to the one below, and that's the shift we're making in terms of the recommendation?
You say number 3. Are you talking about the policy or the fund balance document?
I'm sorry, I'm looking at the fund balance projections. So you're saying number 3 says before approvals, and then there's a section underneath that says unrestricted reserve fund balance. Can you explain, like, what are the differences between those two?
We have a lot, like in terms, so you're looking at the fund balance document, the projected, and then which, do you know?
I'm looking at the 2 3s that you have on
Like
there.
your 302, 199.
This one and this one.
So the second three feeds into the top three.
Desiree,
And maybe we could bring that up because it make it bigger.
do you want to open that one up bigger, Jordan?
Oh,
Yeah.
yes, that's right,
Okay,
yep.
I've got it.
Yep.
I just could not
Yep.
track the math. Okay.
If
Got
that
it.
helps you, Lindy, it took me like a good solid 6 months to.
Yeah. I scrutinized these, but I still didn't understand. So, okay, in my mind, the bottom 3 adds into the
It does.
top 3, but.
Right.
Mine's was
We inherited this document, so
okay.
we also had to decipher what they were doing.
I appreciate that.
I have a couple of questions about, are we dropping down to number 4? Is this part of this discussion or is there more?
Number
So
4
this
in the.
Go ahead, Catherine.
4 on the fund balance projections or number 4 on the actual policy.
On the fund balance projections, and then that's okay. But because one of my questions is around alignment of that number 4 on the fund balance projections with the policy document. One of my questions is that this number 4 talks about 3 months worth of expenses, but the policy document I think refers to 2 months of.
Yes, and I will explain.
Okay, yeah, great.
I have one other question. So 3.2 rolls up into 3.1. But the unassigned is included in
The assigned.
the assigned in the 3 above. That's where I got confused there with that.
Yeah, I'm with you on that too. I didn't understand that.
Yeah.
Yeah.
Okay, got it.
What I can tell you is that our auditors have fully vetted this. This is the approach that even the county uses. So we feel strong in what is laid out here, but we do recognize it is very confusing. To answer your question, Morgan, what you see here is our specific projections when we submitted the resolution to you in December. So this is showing our 5%. What I can share with you now is that our budget looks wildly different from this now. But we didn't want to throw you off because we're not submitting an amendment right now for the amended budget. So we wanted to stay with what you had seen last in terms of the 5%. But that is not what we are suggesting. That's where we were when you passed the resolution.
Okay, yeah, okay.
So
Are we still working through the resolution?
Yeah.
Okay, just want to make sure. I don't want to jump ahead. Okay.
No, you're good. And we wanted to make sure that we could like break it out for you. We did this actually last week and Dira was like, I had an aha moment. So I agree with Dira, but it's like you have to go through it 50 times and then you're like, okay, I got it. So there will probably be many more times where it will be reviewed and through. So specifically, let's go into the next component of the policy, if you don't mind pulling the policy document up, Jordan. And we're going to look at order of spending. So what we acknowledge under order of spending is a few things. In order to preserve maximum flexibility, so I'm on the third page, Jordan, and I'm at the very top. There we go. When an expenditure is incurred for purposes for which both restricted and unrestricted fund balance is available, it is presumed restricted funds are spent first. This is important for us. Many of you have worked with Medicaid. You've heard Medicaid say Medicaid is last resort. That's basically what we're saying our general funds are, is that our general funds are last resort when we have an expenditure. When the expenditure is incurred for purposes which amounts in any unrestricted fund balances could be used, it is presumed the committed amounts are spent first. So again, we are identifying reserves will be used very last, and that we will keep our reserves healthy and whole as long as possible. And then upon recommendation of either the executive director or director of admin and finance, the Board of Health can authorize a different order of spending in specific cases. So depending on different actions that may happen, we never know what's going to happen with our budget, as we have experienced. You may decide that you want to use a different approach, and that's always your ability within this policy. So let's talk about reserve funds. First, we go into what the overall purpose is of using financial reserves. And we wanted to acknowledge, for us, environmental health remediation, audit disallowance, debt abatement, and unanticipated expenditures to adjust revenue shortfalls. And really number 4 is the catch-all. So that's everything else that doesn't or already align there. Then we acknowledge the general fund reserve. The purpose of the general fund reserve is to protect Boulder County Public Health essential services from the potential impacts of unanticipated events. I actually want to go back on one thing that Lexi wanted to make sure I highlighted, which is, for all intents and purposes, the reserves within BCPH are considered the unrestricted fund balance. So if we use the term unrestricted fund balance, we are talking about the reserves. And we made sure to put that in the policy so that we were on the same page about what's being referenced there. And then we acknowledge different types of things that can happen and why we may need to dip into reserves. But then we want to talk about the target balance. So the target balance in the reserve, what we are suggesting is be set at 15% of the total operating expenditures with a maximum level of 20%. 15% reserve is considered a prudent amount to fund essential health and safety services for approximately 2 months. We'll talk about the 3 months in just a second. Beyond a 20% reserve would only be allowable when large infrastructure projects or heavy new system implementation is expected to occur. That's normal standard procedure anytime you go over the 20%. Again, you would approve that. You'd acknowledge we're going to allow for like it to build up for 2 years because we know you're going to either buy a huge piece of equipment, move into a new building, all those types of things that could occur. And then it does say that on an annual basis, the Director of Admin and Finance shall calculate the required reserve rate and provide this information to the board during the annual budget recommendation and amendment. So you will regularly be kept up to date on where it is and the level and standard that we're kept at. This next area is the area that we actually were able to pull from the county. This is the same language that they used. If the reserve funds are depleted below the levels established by the policy, the Director of Admin and Finance and the Executive Director shall develop a plan to restore the balances over a period of no more than 3 years with Board of Health approval. The restoration plan shall include recommendations on rate or fee adjustments, as well as expenditure reductions, reductions in force, and other operation expenses as may be appropriate. Then the restoration plan will be reviewed semi-annually until the policy levels are reached again. And there's a possibility that based on our conversations with the Board of County Commissioners that we may move into this space fairly quickly if you approve this rate at where it is. So let's talk about the 3 months worth expenses. So it is the expectation within GFOA, as well as the state in the PowerPoint that we had, and most governments, that you do 3 months worth of expenses. The percentage of 3 months worth of expenses is 25%. And to speak open and honest with you, I did not think that you were open or would be open to approving 25%. So we modified it to 15 to 20%. So that's where you're going to see the 2 months are in there. But nonetheless, that 3 months has always been listed in there since before I even started. It's just a way to gauge where your reserves are in terms of the overall expenses that you have in your budget that year.
Okay, go ahead. Well, I was just gonna say, but that includes 3 months worth of expenses of all of our, right? That would include grant expenses, and so it's slightly inflated to think of it like that, right?
It would be.
Yeah. Because it would be like if all of those went away all of a sudden.
Yeah, I think that's perfect. The perfect.
Sure, but I mean, for it to all happen in terms of timing all at once too, where all grant funding went away and like everything went away. I mean, I realized that the apocalypse, could be happening.
But from an auditor's perspective, that's irrelevant, right?
Yes. So they want to see that. The other thing that I would say, and I think we can lean on COVID is, and I wasn't with BCPH, but I was with another. And what they acknowledged with our grant funders at the time was they were like, we have to pause everything. We don't know what's going to happen. So please don't spend anything if at all possible, but we still have to provide emergency services in the community. So it does put us in an interesting situation where we have to keep things running, but our funders are hesitant to actually let us use their funds.
Catherine, can I have you re-explain the 3 months versus the 15 to 20%?
Okay, so the standard is 3 months of expenses.
And that's standard by whose standards?
So Governmental Financial Officers Association, which is GFOA. It's also the majority of the policies that we've reviewed, almost every single one of them said 3 months. Some went over 3 months. Those are places in California that have very large budgets. And even the PowerPoint that we received from the state that Desiree found that goes over fund balance suggests 3 months. 3 months, when you calculate it, is 25%. So the majority of those that we found did suggest a 25%, but we recognize that the climate is not as supportive as of that high of a rate. So we moved it down.
I think when you presented to us at the retreat, you all had noted like an 11 to 12% sweet spot. So it seems 15% is pretty reasonable. Is it reasonable that we will build to 15% in 3 years? And if not, what are the ramifications? Should we approve this? Do we just have to go back and be like, just kidding, we're gonna pass a new resolution?
I think that's a great question, Brooke. So it really does depend on where things go in the next period. I think the priority-based budgeting would really assist in this space to acknowledge where our reserves are supposed to be. But the restoration plan would really help assist with how we would get to that space. And that's where there's some elements like we listed in here, including expenditure reductions, changes on rate or fee adjustments, areas that we have the ability to make change with your approval. I don't know what the case is if we don't meet it. I imagine if we didn't meet it, it's because other changes occurred over time, and it would be an ongoing conversation in this space. What I would say is that by getting us to that rate, it puts us in a good, healthy space in terms of our budget. It acknowledges why we're doing it, and it also identifies that if any of these situations were to occur, we are in a space where we can make the decisions to address whatever it is. If it's a natural disaster or something in the community we weren't expecting, an emergency response, we really have the ability to answer it and not feel hesitant, which in the past we have, because we have been told many times somebody may pick it up or cover this cost, and then they don't always.
So we're really looking kind of like an 8% or sorry, 18% year over year, because we're also including that new 1 to 3% unassigned reserve.
That would be set aside, yeah.
Okay. I just think that I think that the reserve is definitely necessary. I can just foresee it causing some strife between the board and the budgeters if we're striving for the 15%.
Well, I think this is like what you're pointing to, Brooke, is a concern I have too, is because, whatever the last time we talked about this is we identified that there are very few sources of revenue that we can put towards the reserve. And if the commissioners don't approve us using unspent funds to put into the reserve, we have really very few options, right, to build up this reserve. So without, expenditure reductions or reduction in force, I just don't know how we would get there.
Yeah.
Can I make one comment real quick?
Yeah.
I think it'll also be important to realize the timing of everything. So if we were having this conversation pre-COVID, it would be very easy to forecast what the percentages are. But we know that we're coming out of COVID still. So we know we have a fiscal of about $2.5 million for next year that we're forecasting. So as we come down, just think about that percentage is also going to shift over time. Am I making sense? That we're not necessarily.
Yeah, it's not going to be, it's on a flat rate. It's a percentage.
It's a percentage. And so the percentage is going to shift the amount of money that becomes available over time.
Right.
So doing a range is also very helpful because then it helps you to kind of not lock into one percentage.
Desiree has her hand up too. You want to see what she has to say?
Hi, I just wanted to add, I haven't checked on this, but by putting a policy into place, you may have audit implications by not reaching your goal in the 3 years.
Heather, what is this policy changing? What's the from to?
Can you, like, in terms of how much money we need to increase to?
What is this, what policy is changing as a result of this resolution?
We don't have a specific policy in
So
place.
this is codifying.
Yeah.
And is it necessary to codify? The worry I have is, well, it's just a question, why? Why are we doing this?
Well, I think that's a question back to you. This was a component that we brought forward as an idea to have it in place so that we could identify with the Board of County Commissioners how our reserves were being impacted by certain decisions. It also, just from an overall health perspective of budget, acknowledges that we are constantly tracking where our reserves are and recognizing the impacts that could happen if we are not set up to be able to actually respond if a situation were to occur.
I'm really looking to codify our reserve policy. And I'm trying to understand from an auditor's perspective, if the standard is 3 months and we are not going to achieve that, how is that viewed when external parties come in to look at our finances?
It depends. Typically what happens when we have externals look at ours is they do an overall risk assessment. So they're not just looking at our financials, but they'll take a look at our audit in terms of our compliance rates, anywhere we've done anything with contracts or purchasing that has not been appropriate. They're going to look at all of those aspects. So they're not just going to look at this one component. The other thing is that if we have it in policy, we're acknowledging this is what our standard is. Rather than the standard that has been out there of 3 months worth, we're saying this is what our expectation is. And there could be lots of reasons for that. That could be related to what you brought up, Morgan, because if the grants stop, some of those programs are going to stop. But nonetheless, what I would also acknowledge is that once it's a resolution, it's not in stone. So we're trying this out to see what the best fit is, but we may find that after, a year or so, it's really not necessary to have this amount, or it is necessary, and we may even want to go a little higher. But we've never had one in place. We have not had a policy that has acknowledged.
And I think historically didn't have a policy that, I think Jeff would keep it around 10%. And I think that was because we were we are an independent agency in terms of having our own board who is overseeing everything, but we are still part of a larger county. And so the county it was an emergency. If it was something happening, we could connect with the county and ask for funds. But perhaps.
And ask for it, right? We'd have to ask for it.
Right. So I think that's why we kept it at 10% versus what Catherine is suggesting about the best practice at being at 25%.
And what did the other public health departments tell you in terms of their standards?
So it did vary. The average that we found was between 10 to 15%. We had some that went up to 25 to 30%. And then I hate to say this, but I'll be open and honest with you. We had some LPHAs that didn't have a fund reserve and were really like asking for information because they're like, we didn't even know that we could have this. And their county typically holds it. So those ones, there was no number.
Were those in counties where the public health department is embedded within the county?
Some, yes. But what we have found in COFAD and also with CALFO is that per statute, the expectation is that they do have some reserves that are set aside.
The retreat, did we have a conversation about whether or not the county commissioners would allow us to use county funds?
We have to ask them. I mean, because I think in the past, actually, the leftover funds had been rolled into reserve fund. And that's part of how we were able to maintain a 10 to 12% balance. But I think we need to get explicit information from the commissioners on how they.
So the county doesn't hold any funds dedicated to public health in reserves.
And I will say that horizon, looks like budgets are gonna be much tighter. And with the adoption of priority-based budgeting, there may be a lot more scrutiny about what the funds are going to. We're already moving into a space where we are working to be much more transparent and accountable for how we are using county funds. So I do think that it makes sense to expect us to kind of be able to stand on our own feet.
I would be very surprised if the county would allow us to keep funds.
Yep. That's right. Which gets back to, I'm very concerned that how we're gonna get to 15% without severely impacting programs. I think I think it's important for us to have a goal, and I think it's good to codify it in a policy. So I am in favor of moving in this direction. I just have concerns about the timeline and how we're gonna get there. But I also think it's part of what then the Board of Health is directing Lexi and your leadership team to set budgeting goals around, and how, you figure out how you're gonna get there.
Yeah, and I mean, I think that's a really good point. And whether or not, if we adopt a policy in the next month around this issue, I do think that having the conversation and having clarity about, what's the ideal target for us will help to guide decision-making as we go forward.
And I think it's also just important to remember why it's there. It's not meant to punish us. It's actually meant to do a good thing if needed, right? And
So we're back in this position.
yeah, we absolutely.
Yep.
And that did happen in 2008. Where the state health department rated the tobacco funds, the amendment 35, about $25-30 million a year. Because the governor needed to have a balanced budget. And so they rated those funds. So it has happened, and then LPHAs get the downhill impacts. So it does happen.
I think also the expectation setting is helpful for the commissioners to understand kind of what we're aiming for.
Could we also just have a future standing item that in 2 years we would revisit this and see how we're doing with 1 year left?
Well, and that's one of my questions that I had highlighted, because it says the restoration plan, which we would enter into immediately having passed this policy, right? We'd have to start on a restoration plan.
I would actually say we would wait till the amendment. Again, if the budget comes through, if it doesn't, because right now we're in kind of a limbo space. But yes, whenever the amended, if it puts us below this rate, then
Well,
yeah.
if they amend our budget, would we bump up 15%? Would we still be below the 15%?
We did a review last week and we were actually right on the 15%.
So, okay, so, one of the notes I put is like the restoration plan shall be reviewed semi-annually, and I just wondered whether or not that was reasonable also, like whether or not it's an annual thing, or if it's an annual thing that we're revisiting as part of the budgeting discussion.
I appreciated the semi-annual review, seeing that it's a 3-year.
It also coincides with the December resolution and the amendment that usually happens in the spring, gives you a semi-annual.
Right, so there are 2 points in time that it would be appropriate to look at that. Another like nitpicky thing, not that I want to get into editing the document, but way up under section 3 on the policy. Where it talks about the general fund, and it talks about the general fund. Serves as the primary operating fund of the Department of Health. Then under point number 2, it says that, and then under point number 3, for the above reasons, general fund resources should be used sparingly, and the general fund should be the fund of last resort. Like, I understand that you walked us through what the spending policy is, but just that to me, it's like, well, the general fund is sort of the core of public health, right? And no. Yeah. Okay. Then I was confused by the language. Is the primary operating fund And then that it should be used sparingly.
So I can understand why that's confusing. The primary operating is just the day-to-day business to get this up and running. But when you think about programs, they typically have their own grant funds or other allocations that come in to keep them up and running. So this is really the like operating, keep the lights on.
Right, yeah, I get that.
Like the idea of having a goal, whether it's trying.
I think it's really important that we adhere to policy as much as we can, and we're using it as a guideline for budgeting. I do have a concern that drops below that we are allowing ourselves 3 years to remedy. That feels like a real period of time.
I think in our current situation, 3 years is not a long time.
Yeah.
We can always, you know, you can always revisit it 3 years in. Now that there's a. Yeah, 3 years, I think sounds pretty reasonable.
And again, the limited sources of revenue that could go into it. I think also we could direct the executive director to have a more aggressive restoration plan.
And we can always change things as needed.
Yep.
And if it's related to a broad economic downturn, that can take a
Yeah.
little while
Yeah.
for a new administration.
Okay, so the request before us is to approve this resolution.
Yeah, so I move to approve resolution 2024-01. Resolution of the Boulder County Board of Health regarding the Boulder County Department of Public Health fund balance policy consistent with governmental accounting standard board statement number 54, fund balance reporting and governmental fund type definitions.
Second.
Second.
All in favor?
Aye.
Aye. Aye. Great. That resolution passes then. Thank you for your work. And, yeah, I think this is what we need to do, the path we need to go on, and it feels like a reasonable percentage. Getting back to our agenda, item number 5.
SIB. So we're gonna do a little switcheroo. So if people on this side could swap with me this SIB, sorry. Not profit. Jordan is the PowerPoint. Jesus.
No, so the one I sent second, there was a slide missing, so the last one I sent is the most updated pre-read. Sorry.
They're not. Big dog is in here.
I think we're good.
And whenever you need to switch slides, just say.
I will do that. So I'm going to be talking first before we jump into a slide. So this may be a slightly lighter topic than the last one. So hi, everyone. My name is Kelly Hinch. I use she, her pronouns. I'm the Strategic Initiative Branch, SIB Director. And with me, I have today our SIB leadership team folks. We have somebody joining online as well, and I'll let them introduce themselves. But we're going to talk a little bit about SIB today and just a bit about who we are. And then each one of the staff are going to present a little bit about some priorities, which should be of interest to y'all, or you may find it interesting for 2024, right?
And we're going to ask you to hold your questions to the end so we can get through folks and things like that. So if you can recollect what those are, Dan will be able to answer all those bases. But I just want to say I'm so happy everyone is here to present this, have a great team, and they do great work. And it's just really, I'm really lucky to have these folks. So, but I want to talk a little bit about SIB first. And I think it's unique, right? In that our teams provide strategic leadership and coordinate some technical expertise across the agency for all of our programs, our initiatives, working as an agency. So we are a pause on a lot of different spaces, right? And that support includes things like strategic planning and prioritization. So we lead a lot of that work. Information technology and solutions, so everybody can do their work, right? And things like that. We have communications, which we'll talk about. And then we have mental behavior health with Dr. LaRocca, who's going to talk a bit about how we help coordinate that space around the agency, and health planning and evaluation. And then also Dahlia is going to talk a little about the admin support, because as part of SIB, the work that Dahlia does also impacts across the agency sometimes. So she's going to present a little bit as well. And, you know, our focus again is to support and maximize our programs and our agencies impact in the community or outputs, and how we engage with the community. So I think before I jump and hand it over to the folks as well, is that people think about SIB as our work internally, and we do a lot of work internally, but we also do a lot of external work as well. Not as much as we do internally, but we have partners like, for example, like tomorrow, we're meeting with Good Sam about their strategic plan. And so we, coordinate in that space with them and our good community partners in that space. We work with BVSD, Boulder County, and people access our website and for general information and things like that as well. So, so it's not just internal work. We're also connecting with external folks in the community as well, beyond what comms normally does. We do that with our other work as well. So, so again, without further ado, I'm going to hand this over. And gosh, I forgot who's the first person. Sean. So I'm going to let you go for it.
Good evening, everybody. My name is Sean Hollister. If you haven't met me before, I'm the communications manager at BCPH. I use he, him pronouns. And I'm excited to share some of our accomplishments from last year and what we're looking forward to in 2024. When I started as the communication manager, we didn't have any tracking systems in place to look at actually how much work the communications team was being asked to do. So that was one of the first things we did, was to put a sort of intake system. And since June 2023, we've had 337 support requests. So that's internal requests from our stakeholders internally. That can range from things like a 5-minute job fixing a broken link on the website to a 60-hour job putting together a 40-page document in Mandarin. So wide range of activities, as well as 36 media requests since that time. So good to get a sort of an idea of what we're actually being asked to do and if we have the resource to do it. That includes, in addition to that work and our daily ongoing support, we have to respond to emerging issues like meth in the library, at the Lamplighter in Longmont, or Winchell's Donuts closing down, which was our most popular media question this year, was related to Winchell's Donuts. And emergencies. So when we have outbreaks, avian flu, those types of things. And we also do a lot of internal comms. So writing a newsletter, all staff emails, that kind of thing. So doing some internal reputation. One of our big projects this year has been a refresh of our logo. Our branding is quite dated at the moment, and it has some problems if you look at our logo, it's not quite symmetrical, and it was just, it served its purpose for a long time. So we decided to just do a bit of a refresh of that. And as you can see up from the previous slide, back at the beginning, I don't know why, this is our new one. It's just an example of how the new branding will be. So you might have noticed the new logo on the top. We also created a communication handbook. One of the things I noticed when I started was that nobody really knew where the up-to-date policies were. I'd have one conversation with one person. They pointed a policy from 5 years ago, another person would point a policy from 8 years ago. So we wanted to have one central repository for all communications related policies, best practice, and just how we go about doing our job and what we can do for the programs to make them more effective. So we're launching a new comms handbook next week as well as the logo at our all staff meeting. So we're pretty excited about that. One of the heaviest lifts that we've got this year is a legislative requirement around the ADA. All materials that we produce, legacy and new, have to be compliant with the ADA, and that is a huge lift for our staff. So we, by far and away, are the largest amount of content in the county. We have 3,000 plus documents, legacy documents we have to look after, and then over 300 web pages that have to come in. Good news is we met with Boulder County last week, and we're way out. So we've got a July deadline. Nobody, from what I've been told, is going to meet that deadline, including the Office of Accessibility at the state level. Their website is not going to be compliant in time, but the news out of the county is that our agency has taken the lead, and we're really out in front of that. So we've designed some trainings. We've come up with some processes to teach our staff how to create compliant material going forward. Some policies work so that statements work when we contract with people. That type of language will always be included going forward.
Good question. What is the ADA compliance specifically involved? Is it just all files have to have an audio version as well? Or?
Great question. So it's a variety of things. That's one possible solution, but there is a way of building PDFs and things so that readers can go through and have a logical order step. So they have to be built in a particular way. There are style things like no all caps headings, because that messes up with the readers. It's also contrast, for someone like myself who's a bit hard of sight. If I see something that's too light on a light background, I can't read it. So it's things like that. It's also how the website is built so that as a machine moves through the reader, we can't have some of the sort of fancy stuff we have in the 90s with accordions and things. They have to be built in a very particular way. I can't remember. Oh yeah, and I just wanted to show you that's the logo we came from. The colors are sort of a bit dated, very, very vivid and 1998-ish. The structure of the logo is a bit asymmetrical, so it never quite looked right with other logos. And so we just brought it into a new square format there where the colors are a bit softer. The Boulder County green has been brought into the branding palette. People are going to have a lot more options to build stuff and make it look professional. And so we think it's a big step.
Great. And there are like, I think, correct me if I'm wrong, but there are like 6 variations on the refreshed logo to accommodate different kinds of needs.
Yeah, so if you need a horizontal, we've got a horizontal. If you want just the tree because you're doing social media or something, just the tree. Just the leaves, some options to make it easier for people.
Very 2024.
Agree.
Any questions?
Good evening. I'm Dina Revis. I'm the IT manager for Boulder County Public Health. We have a team of 3, and we work very closely with county IT on many projects. Go ahead. So the number 1 priority is we have a software called Vision Connect. We've used it for a very, very long time. It was owned by a company called Decade Software, and one of their huge competitors actually bought the software, Acela. And we started moving or transitioning to that platform. Number 1, because Acela is already used within the county. It's used for community planning and permitting, which used to be land use. It's also used by transportation, and it's used by Public Works for their stormwater, since stormwater moved from public health over to Public Works. So that was the logical solution, is to move our environmental health programs into that. We also finished meth last year, which basically you can go in and you can search for all meth investigations, the ones that we had record for by address. So if you wanted to go in and search for an address, you could see all the supporting documentation for that lead or for that meth investigation. We're doing the same thing for lead investigations this year. And that's for, we get reports from CDPHE for children lead, high levels of lead, and we go in and we do investigations. So all the supporting paperwork will also be linked to an address in Acela for lead. We're also moving the body art inspections, which is on Envision Connect, and their plan reviews into the Acela platform. This is gonna help us so much because we'll be able to send out a lot of emails like for invoices if they have an inspection, if they have like a license fee due. And so we are also going to be moving the retail food establishment inspections and plan reviews into Acela too. And we're hoping to finish all of those by the end of the year. And this will really give a better overview of a property. So there's a lot of cross activities like special events. We have people from community planning and permitting involved in that. We also have some of the involved in that. And we'll really be able to streamline a lot of the activities and see all of the activities for a property or a facility. Public health and IT is also going to work with the finance and the county departments to purchase and implement a third-party Medicaid billing system. I don't know if you know, but we bill Medicaid right currently for NFP, for immunization, and for Genesis. And we're hoping that by buying a third-party Medicaid billing system, this will really provide not only to decrease staff workload, but we'll also be able to look at other services that we can bill and maximize our revenue.
When do you guys anticipate implementing that system?
It depends on the county's case because we're partnering with them. They're trying to put a contract through, I believe now, to do the feasibility assessment. I'm hoping it's in place by the end of the year. One bit of information that I thought was really interesting is that apparently Colorado is in the bottom 10 states or 5 states maybe for Medicaid billing for some reason. We just, in Colorado, public health departments are not billing Medicaid. And so we're also looking into what is the root cause of that gap. And so this is a conversation that's happening not only in Boulder County and Boulder County Public Health, it's also happening with a big range of other LPHAs across the state.
It's gonna take a minimum of a year.
And then the other thing that we do is we basically provide technical assistance that help all of our programs. We have a full-time help desk person that runs around all day and gets requests to help with computers.
Restarting.
Yeah.
Turn it off and turn it on.
And try turn it up. So, and we represent like public health on all IT matters, whether they come in externally or they come in from the county. So that's pretty much the work we do. Any questions?
I want to add something really quick with Dina. So on that last bullet point, Dina has done a great job of connecting us with county IT. They are really close, and that makes a huge deal because county IT is now stepping up and paying for things that they didn't do so in the past. It's because it's relationship building. So, you know, Dina's been with us for 25 years, something like that.
I'll be starting my 30 year.
Wow.
So she's great. She tolerates me. And, but, you know, this is, they just do really great, you know, like you can't function, right, without this sort of computer support. So I just wanted to add that.
That's another area where we've been trying to build a relationship with county core departments.
Everyone, my name is Dave LaRocca. I use he, him pronouns. I'm the mental and behavioral health coordinator in CIB. A team of 2 working on mental and behavioral health in CIB, and we're really focused on coordinating and implementing agency-wide strategies, projects related to mental and behavioral health. So just wanted to talk about kind of 3 2024 priorities. So the first one is the implementation of our MBH strategic priority. So exciting that starting this month, we're gonna convene our mental and behavioral health work group who will work to plan and implement our strategic priority for MBH. And this includes, or is the same as our public health FIP. As part of that, as I'm sure you know, there's a lot going on in mental and behavioral health in the state and in the county. So a lot of, what that will include is continued alignment with some of our county partners, like the Behavioral Health Roadmap, our community partners, like school districts, and then also our state partners, the Metro Denver Partnership for Health. The second priority is the MBH ARPA project. So last year we were awarded about 1.3 million in ARPA funds to support our mental and behavioral health programs. So I will continue to serve as the project manager for those funds. And within those funds, we have kind of two new pieces of programming for 2024. The first is a cultural broker who will be focused on behavioral health. So she was hired in February, and she'll be working with our internal programs and also with community members to really create deeper engagement opportunities in mental and behavioral health. We also have a communication scope of work for 2024 that will include campaigns focused on reducing mental health stigma and advancing positive mental health. And then finally, we are doing a lot around policy. Since January, when the state legislature started their session, we've been working closely with our county policy team and with our internal programs to support key mental and behavioral health bills. Just as an example, the most recent one was last week, actually, where we provided testimony for continuing the iMatter program, which is the program at the state level that provides 6 free therapy sessions for kids in Colorado. I think there's been 700 bills, almost 700 bills that have been introduced this session, and many of them have mental and behavioral health focus. So we're continuing to monitor the new ones that are coming out this fall. Good. Pass on to the next.
Dave, it's just, what was that? My tenure, what was that? So the county is recognizing Dave as, what do you tell me today? What was the exact thing? I don't want to get it wrong. So.
The county policy team is aiming to highlight some non-commissioner staff members that are very supportive of the county policy work. They asked if I would like to be honored. I said, sure.
Yeah, no worries. Doing a good job. So thank you, Dave. Yeah, got it.
Everyone, I'm Dalia Mohammed, and I'm the administrative specialist for the SIP team. And in addition to doing all of the responsibilities like invoicing and registering folks for trainings and all the stuff that the administrative specialist person does, I also am lucky enough that I get to go, agency wide. I'm helping IT migrate all of the files from the G Drive to the Teams platform. And that's every file.
Across the agency, not just SIP.
Right. Agency. And then I was also very, very lucky to be able to coordinate with the county and get us included on the translation and interpretation initiatives that they have. So this is going to save us a lot of money in a sense to where we don't have to have it come out of our programs. And they kind of reached out to us, and I met with the folks because we can't process any invoices that belong to the county under the county's codes. So I kept telling them that and then luckily Desiree and we met with the folks down there, and we were able to streamline the process and have them get the invoices to be billed to them directly, and then they'll pay it. And if they have questions, then I'm the point person to where I track all of our interpretation and translation requests. And so I'm hoping that this is gonna be like a start of a good, collaboration or, relationship with the county to be able to be included. This is the first program that we were included in. And finally, after I finish migrating the files, I'm gonna be building the public health page, the internet page, which with Jordan and I are gonna be working together on that. And one thing I didn't add on here is I oversee, or I'm the one that handles the source, or used to be the source, and now it's called the Boulder County Public Health Information Center. I keep it updated when folks send me documents. I put, update the forms and everything, and just kind of
Internal repository.
Yep, and I have all the power. No one else.
That's lovely. That sounds dangerous.
But I always really feel really lucky that I get to not only work with the sick folks, but with the whole agency and everyone. I'm proud of the fact that when people start, they're always like, we see your name everywhere. So I love having that opportunity to be, and I get to meet the people also leaving because I collect the equipment from them because I help out IT. So I'm kind of everywhere, which I like being. I like being just kind of knowing things here and there. After being here for 12 years, I am a familiar face. Any questions? No.
Thank you, Dahlia. We've got one more, and that's Rachel. Rachel is going to join us online. Go ahead, Rachel.
All right, just want to check that you guys can hear me okay.
Yes.
Okay, perfect. So hi, everyone. My name is Rachel Mintel. I use she, her pronouns, and I am the health planner in our strategic initiatives branch. And I am representing our health planning and evaluation team today. We are a team of 3. We have our manager, Elise Wall, who's not able to be here tonight, and our population health epidemiologist, Michael Wu. If you want to go to the next slide, please. Just jump right into what we're focusing on. None of which will be a surprise for you all, I'm sure. First one is our 2024 through 2029 strategic plan. So we're working on finalizing that document based on feedback that you all provided as the Board of Health, as well as our senior leadership. And we are set to have that completed and presented to you in September. That will be the final designed, beautiful version that our communications team will make it look really nice. So it won't be just the content. We're also, as Dave mentioned, starting to launch our implementation groups this month. So our 6 strategic priorities each have a work group, and they'll be helping with some of the revisions in our strategic plan, as well as starting to plan out what the implementation is going to look like. And as the year goes on, actually implementing the work. And then finally, we are excited to roll out our monitoring, evaluation, and learning process later this fall. To help us track and monitor the progress that we're making with our strategic plan. With the next item on our priorities, the data dashboards. We have 2 dashboards that we're going to work on standing up this year. The plan is to have those up and running later in the fall, or later this year, September and December. So our programmatic dashboard is going to be showing measures of success or indicators within our divisions. And then our population health dashboard is going to be including the data that's going to be the high level data indicators that are going to be helpful for our partners, internal and external, to be able to do the work that they're doing and help with monitoring the work. Third priority is our 2023 Healthy Kids Colorado survey. So the Healthy Kids Colorado survey is taken every other year. So Boulder Valley School District is the district within our county that takes the survey. They took it in 2023, and then we'll receive that data hopefully any day now. And Michael will begin working on creating some data tables. So he's going to look at all the different questions in the survey and produce some really nice charts and tables that are going to show the distribution of responses by various demographic characteristics. So we can look at a particular question and see how people responded based on their grade level, based on their race, ethnicity, gender identity, sexual orientation, things like that. Those data tables will eventually be shared on Boulder County Public Health's website, so they'll be available to the public and for our partners to use. And this is a big collaboration with our community health division as they use this data as well. And then lastly, as capacity allows, just like with all of our other teams in SIB, we support our all the different programs in our agency, specifically with planning, evaluation, and data requests. So they reach out to us if they need help with any of those three components. And again, as capacity allows, we support them and help them with their individual programs and projects. And that is all I have.
So much, Rachel. Yeah, so we, in the packet we sent with y'all, there's a longer version of these slides, right? There's a little more details. It has some Gantt charts and things like that related to the strategic plan, et cetera. So I don't know if any of y'all have any other additional comments or questions or anything like that. And, you can always reach out to us directly as well, but if anybody has anything they want to ask, got all the clan here, so.
Familiar with the role of a cultural broker. Do you mind explaining a little bit more what that means?
Yeah, Lexi, you can chime in here, but Boulder County has a pretty long history of cultural brokers. And really they are trusted community partners who are intended to kind of bridge the gap between government agencies and community partners. And specifically, they're kind of intended to help co-create solutions that are hopefully intended to avoid conflict.
They're also folks with lived experience in a particular culture, and they can be staff members too. We sometimes identify that. So it's more than bilingual. It's bicultural. So it's really able to take engagement work to a deeper level.
I had a question about the cultural broker position. Is that, because I know the county commissioners also set aside funding for cultural brokers program. Is this being funded from that county pool of cultural broking funding, or is this out of BCPH funding?
Part-time.
Okay. Thank you.
I just want to add to this, though, that part of this is we really want to dive a little bit deeper on because community engagement is one of our priorities, right? And how do we best use cultural brokers in order to broker those relationships with these communities that we want to connect with, right? It's that, as Lexi said, it's those folks who are just not bilingual or whatever, but bicultural, or maybe for LGBTQ folks or whatever, young people or older people in the mountains or whatever. There's lots of different things we can look at in that space. And so I think that, I'm hoping that we're also able to work with the county, continue to figure out what that space is. Because sometimes I think it gets a little bit nebulous in how we can best use those folks going on and how valuable budget for that.
I have a question about the Healthy Kids survey. I know that St. Vrain does their own survey. I feel like I bring this up a lot, but it does feel like it is a huge gap in our data set if we are not pulling from St. Vrain's at least available data, even if it's not aligned with the Healthy Kids survey.
You don't release their data.
I mean, do they not release it at a even high level to their own board? I would think that would be, and if they release it to their board, then it should be publicly available data. It just seems like it's a huge loss of information about a massive chunk of kids living in Boulder County if we're not looking at the data from St. Vrain. Do you know, Dave, about that?
That's something that we should look into if they at least release it to their board in a.
Right. I mean, if they do, and I know that Lexi and I recently sat down with their superintendent just to talk about strengthening our relationship with St. Vrain. And I think that is, if we have youth mental and behavioral health as a key strategic priority, Longmont, Niwot, those are major parts of our community that we should know a little bit more about what's going on with youth mental and behavioral health.
I can also share, BVSD just released their, I think I can share, I'll have to check with them, but I'm on their Medicaid advisory board. So they did do a review of their most recent data. And I break it down to look at disparities, which I thought was really powerful. Now, I would assume that those disparities exist in St. Frank, the
Yeah,
same
sure.
disparities exist. I don't know if we need their data to show, but they may be exacerbated in certain areas.
Yeah, we're just working in partnership with them if they have their own programs to address mental and behavioral health, especially on their youth, then how can we
Follow up on that.
Yeah, I think we should follow up. Tina.
Yeah, we meet monthly with St. Francis District and convene just kind of a host of community partners who are working in mental and behavioral health. And it is a nice kind of forum for call it just kind of situational awareness around the resources that are available to St. Francis kids and families. So there is kind of a platform in place already for some of these coordination, but I think to your point, yeah, it would be nice to have more data sharing as well.
Yeah, I mean, you're right. I mean, right, you can share programming without the data necessarily, but if we're using the data to inform our strategic initiatives, then it looks like we're missing a piece there.
Are these, this may have already been said, or Rachel can answer this, but are the data dashboards going to be publicly available? Are they internal only? What are we thinking in terms of those dashboards?
So the population data dashboard will definitely be external, right? I think that we're still a little bit of conversation going on about the programmatic data dashboard. And one of the things we're trying to do also is build that in connection with the strategic budgeting OpenGov platform, which we're just sort of figuring that space out a little bit. So, because you want to try to avoid, you know, people inputting data twice, or so we can use the same platform. And they're not exactly, we have two different audiences with two different things, right? And so, but I think we can make it work. And I've been working with Desiree and Catherine and I think we're gonna make it work. But I think that's still yet to be seen how we then publish that or how we put it on their website or not, or what that looks like, or there's a variation. Because the community should know. We should be able to tell community, here's their priority, here's the main things we're doing, here's how much money we spent, here's what the impact was. We were talking about that, yeah.
Of course, the board will get access to it one way or the other.
I don't know about that, but any other questions from you?
Questions? No, thank you, Kelly. Thanks to all of you for joining the meeting and sharing with us more about your work. Okay, item number 6, board business.
To shuffle, I guess.
Wait for the sample. Good afternoon or good evening, everyone. My name is Jordan Thomas. I'm the Business Operations Manager and Board of Health Liaison for BCPH. I use she, her pronouns. And tonight I just kind of want to give you one slide of how you're going to be spending the next 4 or 5 months with me and all of us in here. Across the top, you can see the months now through August and then the different categories. Some of them have changed from very explicit dates to tentative TBD, just based on the ever-changing situations that we find ourselves in. Across the top, those are the actual regular scheduled Board of Health meetings. We will go through line by line. So for the budget, the April 3rd meeting that was referenced by Desiree, that was like an internal meeting we had with OFM. So that was last Wednesday. Switching into May, we originally had an April 28th meeting or April 24th, I can't remember, 24th, thank you, Rick, scheduled with the Board of Health and County Commissioners. Based on County Commissioner availability, that date will now be moved to first week of May, or tacked onto your May 14th retreat. We are still waiting for County Commissioner availability that then we will compare to your availability and then work internally with staff. So that's kind of the cadencing that we're going to do. But we do have the May 13th Board of Health meeting on that regular Monday, and then the following Tuesday we have a retreat planned. Is right now is from 1 to 4. That could change based on Board of County Commissioners availability. I will be in contact ASAP to get that. But it's all in your calendars. Let me know if it's not scheduled. As far as budget, there's still things internally. There's hyphens, there's dashes here. That doesn't mean we're not be talking about it. You will still have standing agenda items or anything that you need to talk about during your board meetings, but there's no special meetings at this time. And then August
that is our TBD for the budget study session. Kind of switching gears, but also embedded within all these different retreats is Lexi's Executive Director Performance Evaluation. So since the end of March through this week, we've been doing some internal development and finalization. Then directly after this meeting, I will step into a room with you guys and get your initial feedback on the process. That will then be incorporated and we will implement this, I believe it's not next week, but it's the week after. I think I'll like double check my calendar. They're all starting to blend together. And then during the May 14th retreat, you guys will have an executive session without Lexi to review all of the collected data that will be compiled between April and that May 14th retreat. Right now I have it scheduled for the first hour of the retreat. We can move that around as necessary. And then moving into June, this is one thing that my preference is for you to have the executive session right before the regular board meeting. So we're not here until 8:30 or 9 o'clock. So I will get that finalized. That's when you will pull Lexi into the conversation to have her formal performance evaluation. And if there's any comments, if you need to get it signed, I have a cover sheet that you can use. That will be finalized by the July Board of Health, Board of Health meeting. It will be finalized in July and sent to me so I can send it and have it submitted to her personnel file. As a reminder, there is no Board of Health meeting in July. There's no special meetings. We want to give everyone a break before we have 2 meetings in August again. So are there any initial questions based on this?
I'm just absorbing also that April 25th one is postponed.
Yes. 24th, yes. It's still on your calendars because I still want to keep all the same people. That way I can just move the meeting itself if I have to. If it's on a day that's not the May 14th meeting. So yes, but it's still on there.
Can you make a request before you set up the entire agenda for May 14th? Could we evaluation to the end of the meeting? I won't be able to.
Okay. I just want to give an update.
Great. Thank you, Jordan. Thanks for keeping us all on track and organized.
If we move to the end of the meeting, we have to be out of here by 7:30.
No, the retreat. So
Oh,
there's
the
the
retreat.
retreat. The retreat's back on. Yeah. That's in the fall.
Okay, got it.
Yep.
Sorry.
Yeah, and thanks, Patrick, for also helping. Okay. That. Okay, item number 7, director's report.
Lexi Nolan, Executive Director of Boulder County Public Health, she, her pronouns. I have no specific items to lift up in the director's report, but happy to answer any questions.
About Family Connects. The Boulder County's Family Connects program may support like some of the Denver health. What does that look like?
Yeah, so it's always possible we have mutual aid relationships with all our surrounding counties. So it's always possible for someone to call a mutual aid because they don't have the resources to be able to handle the migrant crisis because it's a situation and
We would still fund it like through our.
Yeah, we would. Yes. Does that make sense? Yeah. They're, they're becoming really restricted on their capacity. Definitely feels that the team has the capacity to. We said it was 80 up to 10 families.
Question about the participation in the meth task force. I noticed they were focused on reducing meth use. Is there a specific protocol being followed? Has anything been established with the approaches?
So let me back up a little bit. This conversation goes back to a specific conversation related to the amount of funding that our housing authorities are having to shoulder related to meth contamination in public housing. And so the task force includes the housing authorities, the local county housing authorities, municipal, And what we're doing is we're sharing information about experiments different groups are following. We're looking at potential lower cost remediation methods. We are getting a handle on, what would it take to continue to maintain insurance for meth, because that's becoming a problem across the country, is that insurance companies are dropping meth remediation costs, and we don't want to be in that situation. And the reduced use is really, it's not treatment so much as it is, how do we minimize contamination? How do we discourage use in units in ways that are ethical and that follow, public health guidance and are supportive? So that is the initial focus of the work, is really how do we really reinforce housing authorities' finances in ways that still meet the standards that the state has put forth on remediation. And this is a project that also involves CDPHE and the state housing department.
Right, every county has got to be struggling with this, every housing authority.
That's what they're saying. Yes.
Well, but not everyone actually follows regulation. So they don't remediate. Boulder County in particular remediates. Other counties do not test or remediate. So there's
some of them do.
Right. There's got to be other people that are struggling with this, and maybe some who are.
And continuing to, but if we can find lower cost solutions. So the problem is that if you don't test because you don't want to remediate, then you're not really addressing, you don't even know what kind of experience.
Right, you have other public health concerns.
So what our strategic aim is to find ways to reduce the cost of remediation to a level where people will actually feel comfortable testing.
Hey, can you talk a little bit about the WIC program and the conversation that you're anticipating having with the county?
So the WIC, the state is revising its funding formula for WIC. And we are anticipating for the first time to have a match requirement in Boulder County. Most, from what I hear from Renee, our director, many, if not most, counties already supplement their WIC programs, but we have been able to, because that team is super efficient, we have been able to do a great job with the money that has been given by the state previously, but it will take a bite out of us this year. And so I think that is a question that we will incorporate into priority-based budgeting, is support for the WIC team.
And is that something we'll be bringing to the county? You will be bringing to the county commissioners for discussion, or how are you? What's the process for?
So public health will be participating with the other county departments in going through a priority-based budgeting exercise. And we expect that the results of that exercise will be included in constructing our 2025 budget proposal for you in August. And we'll be transparent about that with the commissioners that, yes, this is what we see on the horizon. We're not exactly sure how much it'll be right now. We're waiting for a revision to the estimate, but it will be significant.
Yeah, the team is doing a little research, including talking to other communities to see if the county pays for their directors, if there's, other kind of precedents and how counties are supporting their WIC teams.
I would say obviously let the board know how we can help that conversation with the county. That's pretty concerning.
Other questions specific to the director's report from the board? Okay, thank you. Did you want to, add anything, Lexi, to?
No.
Okay, thank you. Item number 8, old and new business.
Okay, first on our new business tonight, I will turn it over to Catherine Palmer, our Director of Administration and Finance.
Thanks, Lexi. So I have submitted my resignation. And at this time, we have shared it with all the staff within our. We're working on a transition plan to move things over. And so far it's going smoothly, but over the next few weeks or a couple weeks, we'll talk about how things around. And I just want to acknowledge I've really appreciated the experience, the support, the overall lessons that I've learned, but really want to acknowledge how proud I am of the A&F team and all the hard challenges they've been through and their tenacity in this space. And it's been an amazing experience to lead them.
We appreciate your leadership, Catherine, and all the work that you've put in. It's been a really bumpy few years for public health, and we appreciate all that you've done to help us transition and smooth out for time going forward. So thank you.
And wish you much luck in your next stage.
I just want to sing her praises for just a minute because she really has accomplished a lot in a couple of years under difficult circumstances. She led a lean process for our administrative procedures. And I think the overall efficiency improvement was 20%, which are those new processes have been introduced to all of the staff and they will be implemented in June. Catherine led the process of moving us out of the spreadsheets that we were pushed into prior to COVID because the IFAS Oracle conversion was clunky. And we got caught in those spreadsheets, and she and Desiree and a whole host of that budget and finance team and others in A&F really absorbed had a huge learning curve on all of the details of just understanding the spreadsheets themselves and how they were constructed, making sure that they were accurate. And then the process of actually moving everything into the county systems was pretty amazing. And as of tonight, I will add the adoption of a new reserves policy to strengthen the agency. Thank you for that, Catherine. And finally, just to say, I really want to emphasize that she's going to be departing and leaving us with a much stronger and more resilient admin and finance team. It is an extremely high priority for us to maintain the progress that team's made in terms of morale and feeling like they have a leader that they trust and believe in going forward. I will mention a couple of other things of new business. We did have a weekend emergency wind response because that's what we like to do apparently. This was of concern because we have learned a lesson that wind leads to fire. And so we were really watching it closely. We did not have significant fires. We had a couple of little flare-ups, but they were, but I mean, the whole county and BCPH emergency response team working with the city of Boulder and all of the cities in this region really did an amazing job of just being super vigilant and exploring new kinds of emergencies that we haven't had to face with new challenges. The power outages that Excel intentionally shut down the power to prevent fires, which I think made a lot of sense. But it created their own response needs for us. I really want to give a shout out to Chris Campbell, Carrie Middleton, Colleen Sinclair, Giselle Knoll for their hard work and long hours this weekend in the response, as well as Keith and Bob and Stacy and Lane and Jane. And I'm sure there are a few others that I'm not remembering in the moment, but they were working 24/7 over the weekend. Our focus was on public messaging and support regarding food safety, and we made that available in English, Spanish, and Mandarin. Bringing well water systems back online safely, working with CDPHE on options for replacing refrigerated medicines, making sure folks with durable medical equipment that needed electricity had a place that had security for those needs. Monitoring early child education providers, long-term care, assisted living, skilled nursing partners, if they lost power, making sure that their generators were functioning, all of that kind of work. And then we are beginning to demobilize, so putting that one to bed.
And monitoring our own immunization
And thank you. Yes, there was a little scurry to make sure that if we lost power, that in Sunquist that our immunizations, our vaccines wouldn't go bad.
Yeah.
So Lexi, obviously we all just lived through this personally. I think the big issue that I saw with this is the community did not have enough time to prepare for this, which I think was a major problem and maybe put lives at risk as a result. I don't know what the actual impact of some of these decisions were, but people without generators that have medical equipment, people not knowing how to properly drive on the streets, and it sounds like there were some serious accidents over the weekend. I would like to at some point understand the public health impact that the decisions that were made had on the public and what we could do better moving forward. I think this is probably a conversation going on all over the county right now, and it's not just public health's priority, but it needs to be the county's priority and public health's priority to do a better job. I think there were,
and we are absolutely planning to create a new scenario of these kinds of conditions because it will. That's right.
well,
In building the relationship with partners like Excel so that we all know what each other is doing will be critical.
yeah, I don't know what the process was. I don't know how much time the county had, but it felt very last minute.
Yeah, so I do want to make a couple comments about this. One is that the durable medical equipment is definitely something that Chris has said that they're gonna have to work on next for the planning of that. So he has already got his eyes kind of set on that. I do think that with the push to be all electric, I had friends who told me, I have solar, but I have no battery. So the push to electrify and not having energy diversity is something that I think the county and the community needs to kind of take a closer look at. And that's not something public health will lead. But then the third piece is that most urban community members do not prepare for this. I will tell you that if our mountain communities are prepared to leave and evacuate in like an hour, they know where their stuff is, they have a plan. And I do think that as a community, we're at higher, these risks are going to increase. And so we have to do more in the public preparedness space.
I agree. I think there's
And
something
people
around
don't take it serious.
around this that we need to build. I mean, this is not like you said, a lot of people, they're not prepared for things like this. We need to get them more prepared to things so that we can control that. Yeah, I agree.
What were the avenues of communication that we used for like household education, like refrigerator safety?
So most of it, the comms team could probably answer it, but most of it goes, Lane and Sean Hollister will have they already have pre-programmed templates. So then it goes out on social media. I saw the city of Boulder puts it out. They'll just blast it. Yeah, but everything is that we are ESF 8. So we're health and life safety. So we have a very specific role. We work on long-term care facilities, making sure the hospitals don't have to evacuate, that they have their generators are running. So that's kind of our focus, but we're part of a larger Office of Disaster Management, which is ESF up to 30 or something. Yeah. And so we're just a sliver in a larger response plan. So if you ever want to get training in emergency management, please let us know, because we can walk you through what the ICS system looks like and how you can participate, because you can actually go on their website and follow them.
I feel like something as simple as
Just a time check, we only have like 10 minutes.
Okay. For the community, people, I think everyone's learned a little bit through this, and I think everyone anticipates it's going to happen more frequently.
Yeah.
So if there's a way that we could offer community services that are widely advertised so that people can go in neighborhoods and learn and be more prepared. And then I think as much lead time as possible. That was what was so stunning about this, is I don't remember when I got my alert, but it was a day of hours before.
Yeah.
So, if it was already known that this was going to happen, if we had a high wind event, probably could have given the community a little bit more planning. I know I'm hammering something everyone understands because we all lived through it, but it was surprising. too many people.
I'm just gonna, thank you, and I do want to be mindful of the time.
Yes,
We have
thank
to be out of this building in, I think, 8-9 minutes, and we have another agenda
Yeah.
item still, so, but.
Duly noted.
Yeah.
Happy to connect with
Yep.
you and talk.
Yeah, I think.
Okay, I'll just do a quick
Quick
update.
update offline, it's okay, I'll coordinate it.
If we can move to the next one, I just wanted to mention last week was National Public Health Week and the county rankings came out. Boulder County ranked in the top 5, but they don't rank the top 5. So we were not number 5, we were actually higher than that, but it got a little bit mangled in some reporting that was done. But just to highlight some of our really strong areas were life expectancy, child and infant mortality, child poverty, HIV prevalence, adult obesity, sexually transmitted infections, vaccinations, proportion of healthcare providers to the population, social associations, and voter turnout, which are all linked to health. Our teen birth rate is notably low, the second lowest rate among counties in Colorado. And we are 8th in Colorado in access to exercise opportunities. And there are a few areas where we are still looking for improvements, and most of them have to do with mental and behavioral health. So we are glad that we adopted that as our public health improvement plan. The community was right, they nailed it. And our food environment index, we are 9th in the state on that. We have higher air pollution. We do a lot of work in air pollution. And we face particular challenges in income inequality, gender pay gap, childcare cost burdens, and severe housing problems, ranking worse than the state and the national average. So we know where we have our work cut out for us.
Is this report linked? Can we get it?
Yes, and in fact, if you didn't get the
Yeah, I was gonna ask, did you guys get the email
press
from?
release.
Yeah, we found.
Yeah.
It's in there. I can find it and then resend it to you.
Okay. I'll look at it.
Yeah.
And finally,
It's a lot of content.
Finally, there was a great documentary released on PBS recently. It's a 4-part series called The Invisible Shield, and each part is an hour long, and it's about the history of public health and what public health does, which is thank you. We are probably going to be screening it internally and then hopefully with the community later this year. I'd be happy to invite you.
We're wrapping up. We'll be out. Like, so you guys are fine. Take your time. Thank you.
And that concludes.
There's another slide. I'm like, can I talk about the emergency?
That's
response
okay.
officer? Sorry.
Oh, the emergency.
The community, I've been monitoring all the chatter.
Nobody comes from us.
I know.
Okay. I think item number 9 is adjournment. That's it.
Thank you very much.
7:24.
Thank you.
Okay, Jordan, what do you want to do?
So we don't have to meet in a